Hi everyone, my name is Annelies Pervost and I'm a surgical resident at Groningen Hospital in Kortrijk, Belgium. I will be presenting you a comparative study of an integrated ultrasonic bipolar sealing device versus an articulating bipolar sealing device for laparoscopic liver surgery. I have no disclosures. So the first device is a Thunderb device. This is integrated ultrasonic and bipolar energy system, which allows advanced hemostasis through a sealing and cut function, where the two energy flows are combined, with which you can seal, you can cut, you can coagulate up to vessels of 7 millimeter. You have another function, the sealing function, which is purely bipolar energy and which allows secondary hemostasis. The fine tip allows you to do an ultra-precise tissue dissection. Then the ultrasonic system permits to gently skeletonize blood vessels and bile ducts prior to clipping and transection. The synergism of the two energy forms results in a very fast tissue transaction and hence a high operating speed. Then you have the end-seal device. This is an articulating bipolar energy device. So thanks to the 110-degree angle of articulation, you have this unprecedented versatility and you have a greater access in deep or tight spaces compared to other energy devices. The articulation also allows a perpendicular sealing of vessels, which seems to be stronger. Seems to be a stronger seal compared to seeing in a 45-degree fashion. This study is a retrospective analysis of a prospectively maintained database. We looked at patients from September 2011 until September 2020, and everything was assessed in a single super-regional Belgian center. The primary endpoint was intraoperative bloodlust between the two devices. Secondary endpoints comprised of complications being bleeding and bile leak, transfusion rates intraoperatively and postoperatively, operative time, hospital stay, and 90-day mortality. We also took into account several variables, being the laparoscopic liver difficulty score. We looked at the Southampton score as well as the Iwati score. We looked at the extension of resection, taking the classification of minor, technically major, and anatomically major resection. Sometimes we applied the CUSA, sometimes we applied the Pringle maneuver, and when necessary, vascular stapler was used for the hemostatic matrix SurgiFlow. So the results. In total, we had 352 patients. 105 were treated with Thunderb, 247 with the end-seal device. In terms of demographics and clinical characteristics, there are actually no major differences. Age, sex, comorbidity, it was all quite similar. The only significant difference was in the type of primary tumor, where in the end-seal group there were a bit more of colorectal metastases compared to the Thunderb group. Now, bloodlust. This was the most interesting finding. We see that in the end-seal group, the median amount of bloodlust was 100 milliliters, whereas in the Thunderb this was only half, 50 milliliters. So you can see this is really a significant difference. We looked at multiple variables. We looked at the use of CUSA, the application of Pringle, and we did an adjustment of all these factors in a generalized linear model. And eventually, the type of energy device was a significantly contributing factor in bloodlust. In terms of our secondary endpoints, there were no major differences in complications, in transfusion rates, nor in the 90-day mortality between group groups. But we did see in terms of operative time and in hospital stay that there was an advantage for the Thunderb group. The Thunderb group, the median operative time was 115 minutes versus 114 minutes in the end-seal group. And there were 2 days of hospitalization in the Thunderb group versus 4 days in the end-seal group. Now, where does this difference of bloodlust come from? How do other studies perform? We actually did a literature review, and there were 2 relevant studies where the Thunderb device was compared amongst others with an end-seal device. And here, every time the Thunderb device seems a superior device. It showed a higher versatility, a faster dissection speed, a faster sealing speed, a similar thermal spread, or actually less thermal spread or less thermal energy on a microscopic level. So all these factors can contribute in the fact that there is less bloodlust compared to the end-seal device. In terms of secondary endpoints, we did see that in both groups there was not a lot of bleeding, there were not a lot of bile leak. You have to take into account that for the more difficult procedures, we did use cues and we did apply the Pringle maneuver, or we did apply hemostatic devices, so this might have influenced the amount of bleeding and bile leak. We always saw a low transfusion rate, both intraoperatively as postoperatively. Also here we have to take into account that in many surgical procedures, we did do blood salvage at the beginning to have a low central venous pressure and to have less bleeding during the surgery itself. As in the literature, you can see that also in this study, Thunderb was clearly significantly faster in terms of dissection compared to the end-seal group. Thunderb also had a shorter hospitalization stay, but this could be explained by the implication of the ERAS pathway since 2015, which goes hand in hand with the start of the use of the Thunderb device. Lastly, in terms of 90-day mortality, at our center in these last decades, there have been created very fast, elaborate anesthesiological and surgical protocols, which helped in reducing significantly morbidity and mortality postoperatively. Now, the limitations of the study are that this is a retrospective study and that you have to take into account the surgeon's learning curve. end-seal device was applied in his first 5 years of laparoscopic surgery, whereas Thunderb device was used after those 5 years. So he already had some more experience built up. But so in conclusion, in terms of bloodlust, we can say that the end-seal device is a good device, but that the Thunderb device is clearly significantly superior. Thank you for listening.